since we received these referrals and we become pretty saturated in our clinics to be able to see these patients. So this initiative is a 5-year initiative that funds 9 long COVID centers of excellence across the U.S. So it has a demographically distributed population. And what we're able to do with it is really expand care. So we're able to hire additional staff, care coordination staff. So it's really a person-centered, coordinated care model. We're very interested in the patient voice and have patient advisory committees. We are engaging with the community and community allies. So we know what the community feels about long COVID, how we can increase community-based referrals, and that we're meeting the needs of the community. And it also includes a component where we have an iterative evaluation component, again with the patient voice, so that we can continue to improve these care models for long COVID and then hopefully guide policy. And then the last thing I'll mention is, because I mentioned the primary care physicians and just a lack of understanding of long COVID, there's a very robust plan in place to provide peer education through ECHO, through primary care roadshows, through webinars, and multiple education series. So we're hoping to eventually decentralize the care of long COVID in the long run. Again, if 20 million individuals in the U.S. have long COVID, they can't be cared for in only these long COVID centers. Yeah.
All right, Chairman, thank you so much. Let me, again, if you hear frustration, it's my voice. It's begin because one of my very closest loved one has been incapacitated for 2 years. We're one of those families where our loved one has seen 30 doctors. And if you can find, there are not many long COVID clinics around. But let me add my frustration with NIH. As Senator Baldwin pointed out, we gave them over $1 billion December of 2020. They've been focused on, as I call it, forming committees and praying about it. But they're focused on risk factors and causes as opposed to diagnosis and treatment. I really, for Senator Sanders' team, I think we should have NIH come in and I'm not pointing, I am pointing a finger, but it's their processes. They're not streamlined. I think you give somebody $1 billion, we could have some studies done on diagnosis and treatment. And I would suggest that this committee is, maybe giving this type of money more to BARDA, which seems to be more streamlined, more focused on working with the private sector. We keep repeating these same mistakes. We can't take 2 years just to get geared up. So I hope we come back with NIH. We talked about funding BARDA somehow, some way. At its core, long COVID is a vascular disease. It's about immune dysfunction. It's almost like an autoimmune reaction gone crazy, and the spike protein's the pathogen. We know that. And from the doctors on the cutting edge in the private sector, they're getting cytokine panels and coagulation workups, plasminogen activation inhibitors, fibrin monomer dimers. There's microclots going on, too small for us to see on the typical scans that we would use. So those are the types of things I wish we were studying to say, well, here's normal, here's what's happening in COVID patients, those types of things. Dr. Al-Ali, are you doing any of those types of blood work, these cytokine panels, that type of thing?
Not in my lab, but I definitely endorse the idea that we need to find treatments as soon as possible. That's really very important. The research enterprise should be oriented to address the problems that people care about most, which is really treatment. Definitely agree.
Right, but if it would be great if in the primary care setting, if there was a long COVID panel. That's what, like a hepatitis panel, we need a long COVID panel. And then our primary care doctors could identify this and say, yes, indeed. And then maybe based upon that, we decide if we're going to use some off-label drugs like Plaquenil, or maybe we're using acyclovir because we've stirred up the Epstein-Barr virus, that type of thing as well. Does anybody in the panel have any experience using off-label drugs to treat this with some success? Plaquenil is what comes to mind to me. Dr. Walker, you're kind of shaking your head, yes?
Yeah, I mean, there's some evidence for medications like low-dose naltrexone that have already been used in the ME/CFS population. There's some observational data out of Stanford using this medication. Doesn't work for everybody, but is very beneficial for some. And I think that we need to focus not only on curative treatments, because of course that makes sense, but as you heard the panel say today, we just need medications that will cause some relief of symptoms as we're trying to learn more about this disease and find treatments for it.
Okay. Dr. Al-Ali, are you using any medicines off-label with success?
I would endorse publicly, but again, the way we know about what works and what doesn't is to do trials.
Yeah.
I mean, that's really how we know systematically what works and what doesn't, right? Anecdotally, there are a lot of things that people say that these things might work, but I think we need to accelerate trials so we actually find out what works and what doesn't.
So
for
I'm
people with
all
long
for the
COVID.
longitudinal studies, and of course, those take years as opposed to days. I think that we could even start with just some retrospective studies in the machine learning to say, okay, what patients have been given Plaquenil, what patients have been given acyclovir, which one is it, Neurontin?
Low-dose naltrexone.
Naltrexone as well, some of those, just to see. And yes, I'm all for the longitudinals, but desperate times call for desperate measures, and doctors can't be persecuted I use off-label medicines every day, but it seems like if you use off-label medicines in COVID, you're going to go to COVID hell and be censored. So I don't get what the double standard is all about.
No, Senator, we're on the same page. We actually believe very firmly in the value of observational research to really inform a lot of our policy discussions. But at the same time, we also need to really accelerate the conduct of trials so we actually definitively know what works and what doesn't. And those are complementary approaches. And we definitely, most of my lab really runs on observational research, and I definitely endorse the idea that observational research can teach us a lot. And as a matter of fact, it has taught us a lot about COVID and long COVID in the past 4 years. Most of what we know is from that line of research. So we're on the same page.
Thank you. Mr. Chairman, I yield back. Thank you.
Thank you. First, thank you all for... Hang on, I haven't gone yet.
Oh, go. Why don't you wrap it up?
No, I would never think such a thing. Wouldn't even consider it without checking to the co-chair. Thank you all for coming. Know how busy you are and how seriously you take this. You really brought to light a number of different facets that haven't really been considered. I want to ask each of you, and we'll start with you, Dr. Al-Ali, do you think there's potential of directing artificial intelligence? I mean, we've heard so many different novel cases, sets of